with the first talk. I'm sorry to say, but I would be jumping the queue and starting with the first talk, as I have another session as an urgency in the other hall. Dr. Haldipurkar sir was right here, I think. Yeah, he'll come. Can I have the slides, please? Yeah, thank you. So thank you, Hoya, for this session. And we begin with the first talk, and this is going to be basically about the pairing approach to achieve maximum spectacle freedom. So when we talk about trifocals or multifocal IOLs, today we have a lot of choice. And in order to get the best visual outcomes and to get happy patients, I think most importantly, we need to select the right patient. And all of us know that patients who are motivated, who want spectacle independence, more flexible, having the right mindset are better patients compared to those who are very finicky and very fussy. Definitely you need to select the right IOL. Today we have IOLs right from advanced monofocals to the ADOFs, to using micromonovision as well as these trifocals. So using the best lens for your right kind of patient. You need to talk to your patient regarding his functional activities, the distance at which he needs his work done, as well as his daily routine, so as to select the best lens for him. You need to counsel the patient so well, you have to give him the enough chair time so that these patients understand what they are in for. And of course, we have the precise biometry and the surgery for these patients. So in our center, what we believe is having a perfect biometry, which is done with the optical biometry, as well as we use the immersion mode wherever the optical biometry is not possible. In all our premium cases, whether it's the torics or the multifocals, we use repeat readings. We recheck the readings and ensure that all these readings are taken before the eye is touched, even before dilatation and definitely before applanation. Each of these patients undergoes a proper ocular surface assessment, including management of MGD if at all present, a topography in all these patients, in those where you are planning a toric because you want to rule out any kind of irregular astigmatism or any kind of keratoconus which can cause higher order aberrations and an unhappy patient. OCT macula to rule out any kind of very fine irregularities like an ERM or a very fine lamellar macular hole which can be easily missed on even an indirect, especially if you have a dense hard cataract. A pupillometry and an angle alpha to rule out any high angle alpha, especially in high hyperopic patients where it can cause more risks of glare and halos. If you have a patient who have astigmatism, all these patients, you don't have a threshold like say 1 diopter or 0.75 diopters. What we do is we just put the K1, K2 onto the Barrett toric calculator or the Verion if you have, and you see whether the patient needs a toric or not. And we have definitely a very high threshold for the very low threshold for this and a high rate of toric use, especially the low power torics. Definitely discuss these options of either the toric multifocal depending on whether the patient affords it or the other options available. So now going on with my patient. So this was a patient who we can see the pupil is not very well dilated, but we are using a trifocal toric for this patient. So the axis is at 140. We have made 2 side ports and the main incision, put in viscoelastic. And when you have a not very dilated pupil like this, you need to be very careful. You don't want the pupil to come down. And you need to make the rhexis very, very carefully and going just parallel to the pupillary margin. Sometimes just beyond it, and sometimes you can just go parallel to it. A very gentle hydrodissection. At this point of time, sometimes the pupil can come even more down, so you need to be careful. Definitely use of Phenocaine Plus can help in causing more dilatation and as well as viscodilatation. So before even starting the phaco, I use usually a dispersive viscoelastic, a combination of sodium hyaluronate and chondroitin sulfate. You can either do a direct chop or a stop and chop in these patients. Here I'm using the stop and chop with the central trench, and then you make the central crack. It's very important to be in the central safe zone. As you can see, now we are making the smaller nuclear fragments and pulling with the left hand with the Sinskey hook. I'm just rotating it in the anti-clockwise direction so as to make the fragments. You can see the pupil is now slightly coming down, but yes, if you are in the central safe zone, and you can see the right hand is more or less steady, and it's the left hand which is bringing all the fragments towards the tip of the phaco probe. You need to have a very steady anterior chamber with very minimal fluctuations. So here I'm using the signature probe with the peristaltic and the case mode so as to have a very stable anterior chamber. Each of these nuclear fragments are then emulsified very gently. And there is a very thin epinuclear sheet here which also is then emulsified. For the irrigation and aspiration, I put in Phenocaine Plus again to see what maximum dilatation we can get. If probably the pupil was even smaller, then I would have probably used a B-hex in this case. So a bimanual helps to give very, very good control over all the 360 degrees irrigation and aspiration of the cortex. And when you have a semi-dilated pupil like this, it's very important to be careful not to pull on the pupillary edge, because otherwise it will not only distort the pupil, it will cause further pupillary constriction. So sometimes you use the polish mode, and you can go even underneath the iris and underneath the anterior capsule, tease the cortex a little bit, and you can then bring out most of the cortex. So this is the geometric trifocal toric lens. We're putting in viscoelastic, and here you can see the tip of the nozzle that goes into the wound, and it's a very, very smooth delivery, and it goes into the capsular bag. So the pupil is still down, and you can see that even the marks are not seen. In such cases, you can just go in with a push-pull or with a V, and you can see where the marks are, and then you can easily, now you can see we have the Varion overlay, and we need to now rotate the lens to the desired axis, which is almost 90 degrees. So, but before that, we go with the irrigation port underneath the optic to wash off the viscoelastic. This is a very important step, because retained viscoelastic is one of the most common reasons why a toric IOL would rotate. And even otherwise, with the Hoya Vivinex material, it has the sandblasted haptic edges as well as the optic edge, and which gives a better rotational stability. And now we have the IOL aligned. We also have some patients who have given their feedback on this. Obviously, another patient as this was the
घरी टीव्ही म्हणा, मोबाईल म्हणा, घरचे कामं करताना म्हणा आणि वाचन करताना म्हणा, खूप मला स्पष्ट दिसायला लागलं. हे तुम्हाला मी वाचून दाखवते बघा.
So she's speaking in Marathi, but the translation is there, and she is able to read very clearly. These patients are truly happy for distance, intermediate as well as near. So basically what we need is the pairing approach. So what exactly we mean by the pairing approach is the geometric family consists of the geometric and the geometric plus. So the geometric gives almost 50% at distance, so that gives you a very good vision at distance, 17% for intermediate and around 21.8 for near. But if you look at the geometric plus and you look at the second order, that is for near, it's almost 38.6, that is double of the geometric. So that means the increased light distribution for near gives you a very, very good, excellent near vision for these patients, especially if the light is also less. So this is a very important slide, and if you look at the defocus curves with the pairing approach, so you can see that there are three pairs that are shown. One is the geometric in both eyes, the second is geometric plus in both eyes, and the third is the geometric in one eye and geometric plus in the other eye, which is the black line in bold. So here you can see that there is a tall peak for the distance and a very tall peak for the near also. So if you have put a geometric in one eye, the patients are usually happy for distance, intermediate as well as for near. But if you want to give them even better vision, even better clarity for near, then you put the geometric plus in the other eye, so they get the best of both the worlds. So here we get excellent results. So we have been using the Vivinex platform with the monofocals, with the torics, and now with the geometric. So it's not just about the ease of implantation, it's the preloaded advantage as well as the Vivinex technology with minimum of PCO, minimum of rotation, and definitely patient satisfaction, not only because of spectacle freedom, but minimal of dysphotopsia, and all this helps us to give good visual outcomes and boosts our confidence. So to conclude, promising newer technologies helps us to give better visual outcomes to our patients, resulting in happier patients. Thank you so much for your kind attention.